Good afternoon. Welcome to the Heritage Foundation and our Lewis Lehrman Auditorium. We, of course, welcome those who join us on our heritage.org website on all of these occasions. For our guests here in-house, we would ask that courtesy to check that our mobile devices have been silenced or turned off as we prepare to begin. And for those watching online now or in the future, you're welcome to send questions or comments simply emailing speaker@heritage.org. And of course, we post today's program on the Heritage homepage following the presentation for everyone's future reference. Leading our discussion is Dr. Ryan Anderson. Dr. Anderson is our William E. Simon Senior Research Fellow in American Principles and Public Policy. He is also the founder and editor of Public Discourse, the online journal of the Witherspoon Institute of Princeton, New Jersey. He is the author of Truth Overruled, The Future of Marriage and Religious Freedom, and co-author with Princeton's Robbie George and Sharif Girgis of the book, What is Marriage? Man and Woman, A Defense. His research has also been cited by 2 U.S. Supreme Court justices in 2 separate Supreme Court cases, and he has made major appearances on national media as well as in the written press. Please join me in welcoming Ryan Anderson. Ryan?
Thank you, John, and thank you all for coming today. We're in for a real treat. We're going to be talking about a sensitive, delicate, but very important issue. As Americans have entered into what's been called the transgender moment, children have been placed in the crosshairs. As increasing numbers of children are diagnosed with gender dysphoria, parents and physicians alike are faced with difficult questions about human identity, sexuality, especially with mounting pressure to treat children with experimental therapies such as puberty-blocking drugs and cross-sex hormones. These sorts of therapies raise profound questions. Can a boy truly be trapped in a girl's body? Can modern medicine really reassign sex? Is sex something assigned in the first place? What's the loving response to a friend or a child experiencing a gender identity conflict? These are the sorts of questions that we've assembled an all-star panel to respond to today, distinguishing biological fact from ideological fiction regarding the push for transgender-affirming therapies and the dangers of these treatments. So today I will introduce the 3 speakers. They will speak in the order of their introduction for roughly 10 minutes or so. Then we'll have an open time for audience question and answer. And I'll just add that each is speaking in his or her individual capacity. They're not speaking on behalf of any organization. So first up is Dr. Michelle Cretella. And I should add, they're all medical doctors. John referred to me as Dr. Anderson. I have a PhD. Don't come to me if you have physical problems. If you have metaphysical problems, then we can talk. But first up is Dr. Cretella. Dr. Cretella is the president of the American College of Pediatricians. Next will be Professor Paul Roos, Dr. Paul Roos. He's an associate professor of pediatrics, endocrinology, cell biology, and physiology at Washington University School of Medicine. And then last will be Alan Josephson. Dr. Josephson is a professor of child and adolescent psychiatry and psychology in the Department of Pediatrics at the University of Louisville. So please join me in welcoming our panel.
Thank you for the invitation, Ryan, and the introduction. Congratulations, it's a boy. Or, congratulations, it's a girl. In 20 years, nearly 20 years as a practicing pediatrician, that's often how my patient relationships started. Our bodies declare our biological sex. Biological sex is not assigned. Biological sex is imprinted by our DNA at the moment of conception, and it's in every single cell of our bodies. Human sexuality is binary. You either have a functioning Y chromosome and will develop into a male, or you do not, and you will develop into a female. Identity is not biological. Identity has to do with our thinking and our feelings. Thoughts and feelings are not hardwired before birth. They develop over time. Our thoughts and feelings, our self-perceptions may be factually correct, or they could be factually wrong. And I'll give you some examples. And within these examples, you're going to understand or come to see fact versus ideology. If I were to walk into my physician's office today and say, "Hi, Dr. So-and-so, I'm Margaret Thatcher," my physician is going to look at me and diagnose me as having a delusion, give me an antipsychotic, and send me to a therapist. If I walk up to that same physician and say, "I am a man," my physician will say, "Congratulations, you're transgender." There is no blood test, there is no imaging, there is no confirmatory way to diagnose transgender except from the person's word. Take the person's word for it. Because identity is not in the body, it is in our thinking. Another example, if I go to my physician and say, "I am so anxious, so depressed, I'm suicidal some days, I am an amputee trapped in a normal body," I will be diagnosed with body identity integrity disorder. If I go to the same physician and say, "I am a man, please refer me to a breast surgeon for a double mastectomy," my physician is expected to do so. So, most, not all medical organizations, but most mainstream medical and psychological organizations essentially say if a patient walks into you wanting to have a healthy arm or leg removed, they're mentally ill. But if a healthy patient, biologically normal and healthy patient walks in and wants their breasts or a penis removed, they are transgender, and don't you dare tell them anything differently, because that's discrimination. No one is born with hardwired thoughts and feelings. No one is predetermined before birth to be transgender. We know this scientifically by looking at twin studies. Any trait that is set, biologically set, prior to birth will be found in identical twins 100% of the time. So if you have a trait that is only determined solely by, let's say, prenatal hormones changing the brain, by DNA altering the person, that's going to be found in identical twins 100% of the time, meaning that if you have an identical twin who's transgender, his identical or hers identical twin should also be transgender. This is not the case. In studies, the majority of transgender twins were found to differ significantly. All right. Dr. Cretella, why should we believe you? Can you give us an example? Yes, I can. We're not saying these children with this thought process should be ignored. I had a patient, we'll call him Andy. This was a good 10 years ago. Between the ages of 3 and 5, little Andy increasingly played with girl toys, stereotypical girl toys. He really made friends more easily with girls, and he started telling his parents, "Mommy, Daddy, I am a girl." I referred the family to a therapist. Now, the therapist's focus was basically to understand Andy and his family's story, to look at those family dynamics, because oftentimes, sometimes with mental illness in children, it may be due to mental illness in a parent or both parents. It may be due to child abuse, but often children are misperceiving just what may be benign family dynamics. A couple months, it's hard work. Therapy is hard work. But during one session, they had a breakthrough. Andy had a truck and a Barbie. He put the truck down. He looked up at his parents and said, "Mommy and Daddy, you don't love me when I'm a boy." Now the therapist had something to work with. These parents were great parents. They were super parents. But when Andy was 3, he went from being an only child to having a sister born with special needs. The mom and dad were great parents, but his sister needed a whole lot of care and attention. And Andy internalized, and not every child would internalize this way, but for Andy, he did. Mommy and Daddy love girls. If I want them to love me like they did before, I have to be a girl. It's not conscious. It's all subconscious. Now, here's what would happen today. Today, Andy's pediatrician would refer Andy and his family to gender specialists or a gender clinic. The parents would immediately be told, this is who Andy is. Why? Because here's how you diagnose a transgender child. The child must consistently, persistently insist that they are not their biological sex. Bingo, done. You were born this way. Parents, you must socially transition your child, change his name to a girl's name, and ensure everyone else treats him as a her. Because if you don't, he will grow up to commit suicide. The experts work with the family, the school system, and shepherd this child along in this confusion until they approach puberty, at which point, oh, now we must put you on puberty blockers. Because if we don't block your physical development, your child will become very anxious and depressed as the facts of their biology develop. So we want to block them, arrest this development so that we can give the child more time to think. Now, mind you, puberty blockers also arrest brain development, but you want them to think more clearly. Now, what the experts don't share with the family is this is an off-label use. It's not FDA approved. And by the way, when we use the puberty blocker, Lupron, to treat prostate cancer in adult men, it's associated with memory problems. And we found similar findings when the Lupron is used to treat certain gynecological issues in women, adult women. We've never had long-term studies on puberty blockers being used in biologically normal children. This is experimentation. So they start with the puberty blockers, and this physically isolates the child because what's happening to their friends around them? Their peers are growing up. They're being more psychosocially isolated as their peers develop along the normal pubertal trajectory, and they do not. So, we must put them on the cross-sex hormones. What are the risks of cross-sex hormones? So a boy, Andy, would be put on estrogen. If it were a little girl, her cross-sex hormone would be testosterone. These are serious drugs. They, over the lifetime, raise your risk cardiovascular disease. So cardiac, stroke, diabetes, various cancers. These are not benign medications. And they also can cause depression, anxiety. I thought that's what we wanted to treat. This is the standard of care now. It is not supported by science. It's ideology. And it gets worse. If you're dealing with a biological girl who is convinced she is male, once that girl, age 15, if she's age 15 and she has been on testosterone daily for a full year, her physician may clear her for a double mastectomy. I want you to understand the ideological disparity here. The American Academy of Pediatrics, which is the mainstream pediatric group, just came out with a report encouraging pediatricians to talk to their teenage patients about tattoos and encourage your adolescent patients to really talk with their parents because tattoos can be, you better consider them permanent and they can scar. This same AAP is 110% behind a 16-year-old girl getting a double mastectomy. They aren't concerned about the increasing numbers of young adult women who are coming out online because that's the only place they will not be disparaged and harassed. Young women coming out online saying, My physicians and therapists shepherded us along this path. They transitioned us to male. We now have no breasts. We are sterile because puberty blockers plus the cross-sex hormones in young children prevent the testes and the ovaries from maturing, permanent sterility results. So they're waking up at age 28 or so and saying, oh my gosh, what was done to me? There's another area I'd like us to consider, and I will wrap up. This is being taught from preschool through grad school, although it started from the top and has filtered down. The other side is very fond of saying 3-year-olds know if they're a boy or a girl. It's no trouble, no danger whatsoever exposing them to transgender picture books. What the experts are not saying is, yes, most 3-year-olds can correctly identify themselves as girls and boys, but there are many children age 7 and under who do not understand that sex is constant, stable, and permanent. There are many children ages 7 and under who believe, you know what, if a boy puts a dress on and says, call me Daisy, I think he did change sex. I think he did become a girl. And this is why we had in Rockland, California, some of you may be aware, one little girl who had there was a coming out ceremony for one of her 5-year-old male classmates the last day of kindergarten. She went home and completely melted down after getting out of the bathtub, telling her mom, look, Mommy, look, am I turning into a boy? Joey turned into a girl. I don't want to turn into a boy. This is why the confusion is there. This is why it is psychologically damaging to young children in preschool and in our school system to tell them the lie that some people are trapped in the wrong body. You could be trapped in the wrong body. We are undermining their reality testing from preschool forward. If they can't trust their physical bodies to tell them who they are and what they are, who or what can a child trust? And that's what we're talking about.
Well, first off, I want to thank all of you for being here and listening in on this very, very important topic here. And what I'd like to share with you is my perspective as a physician and scientist, and really share with you what evidence is out there for this new treatment paradigm that has very, very rapidly evolved within a period of about a decade. But before I get into that, I think we do need to acknowledge that these children that have a gender identity that does not align with their sex are truly suffering. That is not at question. We know that there's a very high incidence of depression, substance abuse, anxiety, and many other difficulties that these children experience. The question is what we're offering to these children truly helpful to them? And I think it will come to us as a surprise to many of you to find out that despite the fact that there are well-established treatment guidelines, not standard of care, but guidelines that have been presented, and this has been rapidly and very vociferously presented by many medical organizations, to realize that the evidence behind this new treatment paradigm is slim to none. And let me walk you through very briefly exactly where this has gone in a very short period of time. Now, the treatment that is being proposed right now had its origins in a number of studies that were done in the Netherlands, where they began this process of affirming rather than looking at the psychological basis of what was underlying this discordance between gender identity and sex, and began affirming that and then engaging in interventions to align the body to what the mind believed. Now, this came to the United States about 10 years ago. And prior to that time, it was widely recognized that when there was this problem that existed, that there was something that had gone awry, and it was addressed as a psychological condition. And most of the therapy was directed toward trying to understand what was going on at the psychological level and being able to help that individual to be able to come to terms with their body and their gender identity. And almost overnight, the whole paradigm shifted. And because, as Dr. Cretella had mentioned, on an ideological basis alone, it was put forward that the mind was correct and the body was diseased, completely turning that on end. Now, if you're going to take a standard approach to a treatment condition of any sort, not just gender issues, and make that drastic of a change, one would expect that there was either a landmark study that was done, a randomized controlled trial, or a series of very important findings that consistently showed that this is a good idea. The reality is there is no science to back this drastic change. Now, it's not to say that there haven't been studies that have been done. There have been studies, but to make that drastic of a change, and many times looking at studies that in themselves were fundamentally flawed or had various weaknesses. And I'd like to go over some of those with you just so you understand what we're talking about. And what I am saying to you is widely acknowledged by the experts that are putting this forward. I was just at an international endocrine meeting just last month where the new Endocrine Society guidelines were being presented, and the question was asked, what evidence is there that long-term we are doing good for these individuals? And these are the people that put forward these treatment guidelines, and the answer was we have no evidence. Now, what they do have is a series of uncontrolled trials, many small trials, convenient samples, and much that they put forward as the state-of-the-art science. Now, to be fair, when we don't have the answers scientifically of what's going on, we do, in many circumstances, need to act. But we always go forward cautiously, and we continue to investigate. We continue to ask what we call hypotheses. You know, is what we're doing correct? Is there another treatment approach that can be offered to these patients here? And we try to do this with the utmost of care. As Dr. Cretella had mentioned, much of what's going on here rightfully can be considered experimental treatment. But that is not how the public is hearing about this, and this is not what the patients themselves and the families that are dealing with this issue are being presented with. The impression is that this is standard of care, it's well established, we know what we're doing, and this is going to help your child. And it goes even further than that to say, if you don't do this, you are harming your child. I will draw attention, if anyone would like to read, for example, my professional organization, the Endocrine Society, and look at the treatment guidelines. They acknowledge right there in the guidelines, they use a grading system to look at the quality of evidence. And nearly all of the recommendations or suggestions, and they do say suggest, are based on low to very low clinical evidence. The highest evidence actually is presented in terms of complications of therapy. Let me walk you through some of what those are and how this ideology is really infiltrating our medical profession, which is based upon standard principles, evidence-based medicine, which we hold our profession accountable in all other areas, and be able to look at the evidence that is going on and why this ideology is really making its infiltration into this particular domain. As Dr. Cretella had mentioned, one of the early interventions that is proposed for addressing this issue of gender dysphoria is to engage in what's called pubertal blockade. This is a chemical way of being able to shut down normal pubertal development. And repeatedly by the experts, it's presented that this is a safe and fully reversible form of intervention. Yet, there is no clear study that was done in this population. Even looking at other situations, other diseases, and we do use these treatments, these pubertal blockers in children that go through puberty at an abnormally early age and in adults for other malignancies and other indications. But it has not been studied in this particular population. It is an off-label use of the medication, and to make the claim that it's fully safe when you have no data is really an injustice for not only our medical profession, but for our entire society. And to be able to say that quite frankly and be able to share that with the family, that we don't have any evidence. Now, we do have evidence by logic and also by the existing studies that there are some potential difficulties with that. For example, the claim that it's fully reversible is self-contradictory, because what you are doing when you give pubertal blockade is you're interrupting a normal developmental process. Even if 5 or 6 or 7 years later you stop that intervention, you cannot go back in time. You've already altered that development. It is incorrect and totally false to say that this is reversible. It's already discussed amongst the profession the importance of those pubertal hormones in normal skeletal development, and there's concern that they may be at risk of osteoporosis later in life. But probably the most serious concern is the effect that this has, and again, getting back to what really sex is, okay, male and female, the biological purpose of sex is related to reproduction. One of the known major effects of doing this form of intervention is that we prevent that from happening. We actually render these children infertile. And when you follow up pubertal blockade by cross-sex hormones, it's generally accepted that this is going to be irreversible. And again, we're talking about children. Children that have no understanding of what it means as far as their sexuality. They're in the process of exploring that and developing that, and they're being made infertile. And it's and at a time where they are making these decisions at these ages. There are many other risks that we know in treating and giving cross-sex hormones for other indications where we know that there's certainly risks. Some of them are known, some of them are theoretical. It's very well known that the risk of cardiovascular disease when you give these hormone treatments is significantly increased. Same with the increased risk of stroke. There's a potential risk of cancer, not only from the fact that individuals that are presenting as the opposite sex aren't getting the normal screening tests that they would need for the particular organs that they have within their body, but the hormone treatments themselves may influence that as well. So I don't have time to go through all of the concerns, but I hope that at least that brief introduction gives you an understanding of what we're putting forward as established science as the only way to go is something that needs to be challenged, and it's certainly something that is a threat to our practice of medicine and to scientific integrity itself. For any investigator to put forward an alternative hypothesis to this current treatment paradigm is met with hostility. In science, we often will ask questions, we will test the evidence that's presented, present alternative views, and be able to try to search for better, more effective, and safer interventions. That discussion is not currently going on at the level that it needs to go on. And that's why I thank all of you for being here today to join in this conversation and to join all of us in raising awareness for what's going on within the medical profession and really making plans for the future to correct the errors that are going on at this point in time. Thank you very much.
Okay. Again, thanks for the invitation. I'm delighted to be here. And I'm, of course, the psychiatrist here. And in fact, that's probably very appropriate because this is a sociocultural, psychological phenomenon. And the fact that we're even talking about using medicine to solve it, I'm trying to remember, there's a kind of a joke of the guy looking for his wallet. He lost his wallet. And somebody said, well, you lost it down the street. Why weren't you looking down there? He said, well, here's where the light is. That the real issue is down there. I thought of coming up here and like, why am I here? I think I'm here for two reasons. One, I have a commitment to the idea that parents, children need help, and they're not getting help because of this phenomenon. And I'm not going to use the word abuse, but I want you to think about for a few brief moments the idea of neglect and give you some examples of why this is a neglectful phenomenon, neglecting the developmental needs of children. And I'm also here because I think truth matters. And Michelle and Paul have been clear about things that are just not true, and there are a number of things that are just not true in this sociological phenomenon. So I've testified in a number of cases over the last several years as this thing has just mushroomed. In one of the declarations I read, the physician said this: "The cost of not assigning sex is dire. It is counter to medical science to use chromosomes, hormones, internal reproductive organs, external genitalia, secondary sex characteristics to override gender identity for the purposes of classifying someone as male or female. Gender identity should control when there is a need to classify an individual." I was stunned when I read that. Counter to medical science? Chromosomes, anatomy, physiology, genetics. This is medical science. That's how we categorize things. But that should take second place to this feeling, this notion of gender identity. Unbelievable. Can we cue up that video? Somebody here? Take a look at this and enjoy it. It's about a minute.
All right, Shannon, can you count? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Yay! All right, ABCs. A, B, C, D, E, F, G, H, I, J, K, L, M, N, O, P, Q, R, S, T, U, V, W,
All right, so why did I show that apart from my grandfather's narcissism? That was my that was my son, you heard, who actually just worked a number of years down at DOJ here for 6 years. He's now in Georgia. But this child waited for the father to prompt her, 20 months of age, at every point. She didn't have any idea of what she should be saying, except he told her, B, C, D. And this is what parents do. So it's impossible to speak about gender identity without thinking of the parent-child relationship. When you think of it, children don't know much about anything. And I say with this respect. I've raised 3, I love them dearly, they're doing well now in their lives, but they don't know anything. So at the age of 7 or 8 or 9, well, why should we listen to a 9-year-old about time they're going to go to bed? We don't let them vote, we don't let them drive. And so we're going to let them, at the age of 8 or 9, decide that they're no longer a male or female. Unbelievable, unbelievable. And we don't allow children to do this. And in fact, this boy, the young man who's giving direction there, when he was 8 years old, he said, "I'm going to be in the NBA, so I don't need to go to school anymore." and his mother said, "Well, you need to go." And then he countered. He was a tough kid. Well, I've already gone 3 years. We made him go to school. And of course we chuckle because but that's the amazing neglect of the need for child development. So neglecting that, and when parents abandon being parents, then we're in a lot of trouble. So this notion, and Michelle's already mentioned it, the persistent, consistent, insistent way that a child expresses that I'm a male or female, that is proof that it's true. How many people here have children, by the way? All right, so half the group. Well, you all know that children persistently, consistently, insistently demand lots of things that aren't good for them, that are bad for them, and they resist what is good for them. Time to go to bed, turn off the computer. The child says, "Well, that's a good idea, Mother. I was actually thinking of that." It's part of normal development to resist change, and it's part of the parent's job description to do this. Children's experience in life is limited. And so that's what needs to happen. And that's what's missing, a core part of this in the transgender business. In addition to guidance, children need structure. A friend of mine did a lot of camp work, He was actually a philosopher. He was a very thoughtful guy. But he did an experiment once. He had a bunch of 10, 12-year-old kids on a hike and said, isn't this great? We can go wherever we want. We can jump over a creek. We can climb a tree. We can throw stones. There's no stop signs telling us. It's just great. And the children enjoyed that kind of idea. Later on in the day, what happened? As the sun began to set, one of the kids came up, unbeknownst to the others. You do know how to get home, don't you? The children panic without guidance and structure. They also need the instruction, so the truth of the facts of life. Chandler here needs to know her ABCs at some point, and it's a gift of parents to give her that. Briefly, transgender ideology also is neglectful of the need for developing coping skills and problem-solving skills in children. I want you to think of pain for a minute, and pain in a generic sense of distress. When doctors see pain or distress, what do? We try to figure out the cause of it and map out a treatment. We don't ignore it. We don't walk away from it. We ask questions: where does it hurt? How does it hurt? What makes it better? And so forth. And when that kind of questioning is not being asked, in fact, it's off the limits in some legal attempts have been made to crush that, we're abandoning children. We're neglecting a potential diagnosis. And it's not uncommon in the movement, and I will call it a movement, right? To hear it's incredibly harmful to have these children go into the bathroom of their genetic sex. It's just too stressful. Well, in the process of development, we're always subjected to some kind of stress in developmental crises. There's not a person here in this room who would be here otherwise, I'm sure, if they ignored some of these developmental challenges, which were difficult. All-nighters in college, studying something that you didn't understand, grappling with courses that you didn't want to take but had to take. It's part of development. But with these children, when they have, I'm uncomfortable, that's all it takes, we walk away from them and abandon them. And if we ignore pain, the bottom line is that we might miss a diagnosis and a chance for developmental progress. Now, the activism that's out there also prevents us from diagnosing accurately. As Paul mentioned, depression, anxiety, substance abuse, it's abundantly clear that these youth have multiple more psychiatric problems than other patients. Controlled studies have shown that, even more than other LGB patients. And why is this? Well, we need to explore it. A recent patient that I saw really 2 weeks ago told me she was a genetic female, but she wanted to be called Matt. Her name was Madeline. She said, I identified as a male at 12. I was so much more comfortable with that. Again, that word, avoiding distress, avoid discomfort. Treatment paradigms just can't do that these days. But so much more bad stuff happened when I was called Madeline. She was abused badly. It was horrible. I didn't want anything to do with that person and what had happened to me. And there are dynamics of all these kids, these adolescents who are in difficulty, almost all of them. So I said, have you talked to anybody about this? Have you ever talked to a professional about this? And she said, no. I simply said, well, would you like to? She said, well, now is probably a pretty good time. It was actually exquisite but elegant in its simplicity. Any good therapist behaves that way. But in this area, it's hands off. It was just a simple question. Have you ever talked to anybody about that? And she hadn't. And so we've continued to do some therapy. A comment briefly about the stigma, and then we've got to end here. Stigma is not enough to explain all the mental health problems. It's not a unitary hypothesis that explains everything. And that's the only thing that can be said by, if you will, the other side. I have deep concerns about families who struggle. They're getting this message, and what is the message? We could all say it in unison. If your child comes home with this, Mom, I think I'm a boy, kind of thing, you affirm her. What? Of course you affirm the child and love the child, but you don't affirm a bad idea. But that's what's being said. And one of the therapists in the clinic that I directed said, I don't need to judge this boy. My response to her internally, and she and I are working through this, but was absolutely you judge, not in a moral sense, but make a clinical judgment, a judicious judgment of what is going on, and why would someone come up with this idea. I will end with this. that there's a strong move to push gender dysphoria out of the mental disorders nomenclature in psychiatry. And it's very powerful. Activists believe that having it there, of course, creates prejudice. And we've had precedent in psychiatry. Get rid of the diagnosis and you get rid of the prejudice. We're all normal. But it was left there because the patients needed what's called access to care, read insurance. They needed to get that insurance. And in order to get that, they needed a diagnosis. But they're still trying to get it out of mental disorders and placed into another category, and the World Health Organization is working on their ICD-11, it's called, to try to get into a medical diagnosis. So we'll end with this to follow the tortured logic. And there's no area of medicine and really psychology, human development, that has as tortured logic as this one. We do not want it to be a mental disorder, but we need it to be a mental disorder to get treatment service access. But then, what are we getting access for when it's not even a disorder to be treated? Let's think about that logic. Which makes sense. Why would you have insurance coverage for something that's not a disorder, which is where it's headed? But then the only disorder that's left is the stigma and shame and embarrassment that you've created. When I say you, meaning culture. We've created that in them. Tortured logic. And that has really been an overriding principle of all the things that you've heard here.
Thank you. So we now have plenty of time for questions and answers. Please wait. Just raise your hand. I'm going to call on you. Wait for the microphone to come so the people who are live streaming this will be able to hear your question. Just briefly identify yourself, say who you are, where you're from, and then ask a question that ends with a question mark. And we'll go to the two people right in the middle. The lady first and then the gentleman right in the middle.
Hi. I'm sure that this didn't come from nowhere. I was wondering if you could talk a little bit about the transgender lobbying and how that's affecting it and the threats of malpractice if they try to do other kinds of treatment.
Well, I can begin, unless you want to, Alan.
Good.
With just my own experience from my own profession and what has been put forward to us. And it's clear that the advocacy efforts are driving much of what is going on here. And I would say to the point of putting forward one hypothesis and excluding all others, and being able to actively attempt to silence those that even raise the question. So that is what is going on. I have a number of, when this came about, my involvement in this whole area started about 6 years ago when there was an attempt to begin a transgender clinic at my institution. And in looking at the evidence and having concerns, it was very clear early on that anybody that disagreed with what was being put forward as established paradigm, the gold standard of treatment, was really silenced. And this happened at many organizational meetings, at national meetings, where the panel, to have a non-biased discussion, was loaded with advocates and those that were questioning, not just questioning, were essentially silenced. So that influence of advocacy, and I think the intention is to move forward with one hypothesis. That's not the way science is done. We don't come up with a hypothesis and without gathering the evidence say we don't need to do any more studies and we should stop anybody from asking questions. That's very contrary to the practice of medicine and science. So I think that aspect of advocacy is very clear.
It's a beautiful question, and where so much of this revolves around in that these youth need treatment. They need help. They don't need someone arguing for their civil rights. A civil right, that's without saying. That's a no-brainer, right? Of course. And all of us up here involved with these types of patients respect them deeply and care for them. But the truth is really what matters, and that it's not really decided by a show of hands, is it? Which is what happens with the advocacy process. And I think we've all been involved with this silencing, and I laud you again, Ryan, for organizing this, because it's part of having a dialogue. But I've been involved with several professional meetings where a controversial sexually related topic was on the agenda and have had several of them removed after they'd been okayed by a program committee. These forces are powerful, and their activism, they're not, as Paul says, they're not based on data or reason. They're basically based on shouting. The larger and longer that you shout, you can get your way, and that's, again, that's how science proceeds.
And I'm so sorry, I will be very brief. But to add to that, it's so important for everyone to understand that this is not a right versus left issue as it's being portrayed. As president of the American College of Pediatricians, I've received emails and phone calls from a number of LGB affirming physicians, endocrinologists, surgeons, therapists, psychologists, saying, thank you for speaking out, because we're not in a position to do that. We will lose our jobs. Now, I encourage all of you here to go online and search for youth gender professionals, because many of the individuals who've contacted me are posting and blogging online their youth gender professionals. And their perspective is priceless. It's very important.
I am a retired physician. I would like to ask the panel, especially Dr. Josephson, how many patients you had that had a transgender identity that you cured by psychotherapy? And to the crowd around here, I suggest there is a very interesting documentary on, I think it's Discovery, it's called I Am Jazz. And I suggest if you didn't have a sense of see it.
Well, I think curing by psychotherapy is an interesting phrase. There are very few things we actually cure by psychotherapy, but identifying some of the risk factors and what seems to be related to the onset of a disorder is what we try to do. I think the reverse is also true with the medical, as Paul was pointing out, findings that how many are cured from these medical interventions, and there's no evidence that we've done that. I think that the thing that I start with is the human problem and suffering, and how one evolves to believe they're another sex. And it's often, there's pain, there's abuse, there's neglect, there are all kinds of problems there to be solved. And so that's what I try to do. But cure, in fact, that's an even interesting question about medicine. How many conditions do we cure in medicine? If you ask that question, that's an interesting question as well.
And I'm going to just add one more component. Since we're talking about children, we need to raise the available evidence of what developmentally occurs in the vast majority of children. And this is challenged by the advocates, but there are over almost a dozen studies that have been done over about 20 or 30 years. Some of them have problems, limited studies. The more recent ones are a little bit larger, consistently show that the majority of children that have a transgender identity, if you merely leave them alone, will have resolution, will have realignment of their gender identity with their sex. That's not to say about the percentage that don't, that have persistence, and that's a different question. But there is a large group of individuals that are presenting with gender dysphoria or gender identity issues that actually is part of their normal development. And the concern that we have, there's about a huge increase in the number of children that are now presenting to transgender clinics for care. And it's not clear whether those individuals are the same individuals that were presenting 10 or 20 years ago. However, it's put forward as dogma that the reason why they are presenting is because they were always there and then now they feel they have a place to go. But it can be asked as a hypothesis that can be studied. Are we influencing the normal trajectory by what we're offering? Are these children, and by some estimates, 95% of these children will align their identity with their sex, not need any hormone treatment, not be sterilized, and have very healthy, productive lives? And so closest to what I can say is what we would say is a cure. And in the process of what we're offering to these individuals, are we influencing that? And that is a question that truly needs to be asked. And so it doesn't apply to all of the individuals. There are still many questions that we don't have, but I think that perhaps addresses a component of your question.
So just to underscore what Paul just said there is that 80 to 95% of children with gender dysphoria would naturally grow out of it and have a realignment of their gender identity with their bodily sex. And the proposal now is to have these kids socially transition, then be placed on puberty blockers, then have cross-sex hormones, and then have surgery, which could lock that in. So more questions. We'll go, Walter, down here in the front, right by the column up here in the front.
Thank you. Walter Weber, American Center for Law and Justice. I heard reports in the past of female athletes taking, I guess, testosterone to enhance their physical capacities, specifically in communist countries. Two questions associated with that. Have there been studies of the effects of that practice? And is there a precedent in medicine condemning it, which has to be overcome in order to forward this transgender agenda?
Yeah. So in like many areas, there's very little science investigating this. We do know what the effects are of what we would call inappropriate levels of testosterone in a female. And we know many of the effects that go on with that. And it is dependent on the dose that you give and for the duration that you give. The experience of giving it in that particular circumstance, it's very interesting when you're giving it for performance enhancement and getting around the prohibition, the known prohibition, the effects of testosterone on athletic performance, now saying, well, I'm not doing this to improve my athletic performance. I'm doing this because I'm transgender. And then we have to ask, and it goes in both directions. We know the effects of testosterone and what that does for athletic performance, but it doesn't really change that individual. A female that takes testosterone is a virilized female. And it's presented as, in the transgender area that they've now suddenly become male. In the other direction, having a male that is given estrogen and efforts are to suppress the testosterone, the hormones themselves will influence athletic performance. And there are very clearly reported stories of athletes that have been distressed by the fact that they're not competing at the same level. Yet, there are other aspects of their fundamental biology that does not change when you give them hormones. For example, their skeleton doesn't change. Lung volume doesn't change. Many other components that actually influence athletic performance. So when you're going from a male to female type of transition, again, some of the concerns from the fairness of competition are there. So many different aspects in your question. I hope I addressed the primary ones that you had. So.
Yep.
How you doing there? Derek from Cure. Question for you. I know about a second grade child in a school that's dealing with this, and so the teachers were instructed to not call this person by their male or female thing. The question is this: how can parents recommend or maybe even combat this issue in the school? Because I'm thinking, based upon what you said, other kids in the school are affected by this with their own questions that you're injecting into this situation. But how can parents combat this from a school perspective? Because the schools seem to reorient everything around this. And I'm thinking, based upon what you said, there's evidence that, we may be able to submit to them. So what are your recommendations in that regard?
I was just going to quickly, around the school issue, this doesn't help a child developmentally. It's hard to talk to someone I'm not seeing, but and that basically to do whatever a second grade child wants or it just isn't helpful for him developmentally to challenge that. And so the idea of the school making an edict, and it wasn't clear in that instance who just said that you must talk to him as right, and that's part of the caving into the pressure. The approach is to treat the genetic sex and that help them align with friends who might be boys who might be with other boys who are a little more effeminate or girls who are a little more masculine, and not to give in, because it's very confusing to children. Children do not understand this, and we have to remain firm on that, basically.
So more to your question, what can parents do? Fortunately, the Obama suggestion to colleagues was in which the Obama administration essentially said to all schools, you're in danger of losing your federal funding unless you impose this transgender ideology. That was rolled back. So parents, first of all, have to be aware that the current administration did remove the Obama administration suggestions. So parents can feel emboldened to join together and advocate for their children at the local level, starting with teachers, administrators, and you have to pack the school committee meetings. That is where your power lies. It's hard work. And I know this, I'm sorry, but again, at the American College of Pediatricians, I receive phone calls and emails. Dr. Cretella, can you help us? Could you just write a letter and make this go away? I wish I could. It doesn't work that way. We can help by backing up the science behind it and what's best for children, but it's the grassroots parents advocating for your own children. And sadly, sometimes you may have to simply pull your kids out.
I think the point about parents, in any ways in which we can empower them to let them decide. So my whimsical story about the third grader wants to go to the NBA, you just say no. You're a boy, you're a girl, but parents are so intimidated these days and so on the run, and then when there are legal edicts to kind of support that, it's very difficult. But we need to empower the parents to be parents. Of course, the problem in the real world, many parents are alone, many parents are in relationships that undermine their decision-making, and all the fragmentation of the family then comes into play. But when you step back on it, second graders shouldn't run the world. And that's, and parents need to be strong enough to respond to that.
Yep, in the back corner, and then the other back corner.
Hi, thank you for being here. My question is if you think there's any place in medical treatment for addressing people with identity crisis with medication. So a girl that thinks she's a guy getting female hormones, or like that, along those lines of that kind of treatment. Do you know what I mean?
I hear you.
No place.
Yeah, right. So in other words, a girl or a woman who feels and believes she is a man, giving her, the problem is not a hormone problem. These individual patients, they have a normal genetic makeup, normal hormonal axis. So giving a woman more female hormones, that's not the issue. So it will not help.
Okay, I guess in follow-up, is there ever a place you think that gender identity could be chemical imbalance? Is it always just that they have, it's obviously mental for the most part, but is ever a chemical imbalance or something where they're medically off?
So I will go back to the twin studies. We do know from twin studies that transgender identification is more common among twins than within the general population. So there's likely a predisposition, but vulnerability or predisposition is not destiny. And it's the same thing, in fact, for anorexia nervosa. And I've pulled twin studies for anorexia, twin studies for transgenderism. There's actually, based on the numbers, a stronger predisposition, a stronger biological predisposition for anorexia than there is for transgender. And yet, we don't have anyone saying, oh, anorexic, you were born that way, so sorry, we can't help you. Nope, we just have to get the world to accept you and figure out a way to do liposuction but not let you die. So we're made of DNA. Every complex behavior is a combination of our DNA plus environment. And the twin studies can help us figure out, well, what trumps what?
There's no condition in psychiatry in which the term chemical imbalance hasn't been invoked. The problem with that is that what is a correlate of an event and what is causative, that almost all conditions have chemical associations with them and are imbalanced or balanced. But whether that's the cause or just a correlate. So when I get when I was raising my son here years ago and get mad at him, you could do a chemical imbalance printout on me, but no one would think of that as a chemical problem. But psychiatry has huge kinds of issues with that. But there, again, to what Paul said, there's just no evidence that in transgenders that this is there.
I think your question relates to one area of scientific investigation which really needs to go on. Now, we do have some evidence, actually, about the influence of androgens, for example, in conditions where they're abnormally present at a time of development. And it's not the whole answer, as Dr. Cretella had clearly said. Most of those individuals, for example, girls that are exposed to testosterone early on, have more masculinized behavior. So they actually prefer a tomboyish type of behavior, but their identity is in accord with their sex. Is that absolute? There's a lot that needs to be investigated, but it is not fair to say that it is known to the extent and how that interplays with the other factors, that if there is a critical role of hormone exposure at one point in time, it's, with the evidence we have currently, it's not the answer, I think, but we still need a lot of work to understand that better.
So we're a little bit over time, so we'll have Zach Ford ask the last question, and then we'll wrap up, and we have sandwiches outside the doors.
Zach Ford from Think Progress, as Ryan correctly identified. Dr. Josephson, in your brief defending North Carolina's HB2, you described transgender people as experiencing delusions. Dr. Ruse, in your in the same case, you argued that it's always the greatest lifelong benefit for all trans people if they can be counseled to embrace their natal sex. Dr. Cretella, you regularly refer to affirming trans kids as child abuse, even though there are studies showing that when parents affirm their trans kids, virtually all of their mental health disparities completely disappear. And so I'm wondering why, if you all have beliefs that stand in stark contradiction to almost all of the major medical organizations and that reflect a clear prejudice against trans people, why this audience or anyone else who hears you speak or reads your briefs should trust that you actually have the best interests of kids in mind.
That's a great question. Thank you. All right. Chemical castration, which is what you are doing when you put any biologically normal child on puberty blockers, is treating puberty like a disease, arresting a normal process, which is critical to normal development, bad for kids. Sterilization, not good for kids. Prepping them for what will likely result, in the case of girls, double mastectomy at 16. Not how you treat depression or anxiety, and I have plenty of experience treating teenagers with depression, anxiety, even suicidal depression. Indoctrinating preschool kids with the lie that you can be trapped in the wrong body. Again, that's disrupting their normal reality testing and cognitive development. Those things are abusive. As to the studies, there are two that I am aware of which claim that affirming your child's gender confusion is good for them. Number one, it assumes that coaching a child into a fixed false belief is mentally healthy. Science doesn't allow you to assume your conclusion. Number two, those studies are extremely small. Number three, those studies are very short term. And number four, the control group of mentally healthy children are the siblings. Most of them were siblings of the trans-identifying child. Oh, and there's a number five, the parents were the ones evaluating the mental health of the children. This is not science. I don't think you need to have an MD or a PhD to know that's not science. That's ideology masquerading as science.
And to objectively look at the data and the argument, as scientists, the challenge that is being put forward is to act as we do in the medical profession and as scientists of presenting hypotheses and looking for the evidence and being able to come out with the best outcome. The putting forward the best outcome as far as the desistance that can occur in the majority of children, puts them in a position where they retain their normal fertility. They're not exposed to drugs that we either know or suspect that they may have harmful effects. So to say that that is preferable to engaging in the current treatment paradigm is just a factual statement as far as needing treatment or not needing treatment. It's not a judgment on their well-being as far as their psychological well-being, but that is the best outcome because then they're not subjected to all of these harms that we know that they will experience if they move forward with that. And the challenge is with the paradigm, it's being put forward is that there's only one solution to affirm this and then go forward with hormone therapy. And then you're subjecting them to all these other risks. And so I think that in the scientific realm, there's no room for, as you termed it, prejudice, because we ask hypotheses and we test that with the truth. We search for the truth by testing it with experimental evidence with what we have forward. And that's how science moves forward.
I know we're running out of time, Ryan, but I got two quick ones because I was named in that question as well. I think in terms of the affirmation business, if you hate calculus, you can't do calculus, you struggle with it, you think it's the bane of your existence, and then someone tells you, you know what, calculus has been removed from the course load this year, you're not going to have to do it. You have immediate relief. You feel terrific because something that's been difficult has been removed from you. And so for the transgender person to not have to deal with the realities of their genetic sex, of course there's an immediate response. These studies have not been looked at very long, as Michelle says. It's in their question and answer checklist kinds of thing. We don't know about that. We do know that the child needs to be affirmed, and I hope that everyone sees in our clinical practices here, we care for our patients and we affirm who they are. But the second thing, and this is a longer question, but the clear prejudice notion. Much of my work in psychiatry the last 15 years has been how the worldview of the patient and doctor interact. Because for a long time it was thought that the psychiatrist was a neutral observer. Well, the psychiatrist has a worldview and it interacts with the patient's worldview. And that's true with all of us. So whether it's prejudice or not, we have certainly who we are and how we come to see things, but no more prejudice than any other person who looks at this because we all have a worldview, including everyone in this room.
So I just want to thank our three panelists today for their devotion to their patients and for their courage in defending their patients' well-being, even when it's not popular to do so. So I want to ask you to please join me in thanking them today.